Precision medicine in critical care seeks to subclassify heterogeneous syndromes like AKI for more effective treatment. However, there's been confusion in terminology like phenotype, subphenotype, endotype, and treatable traits. Phenotype refers to a set of clinical features shared by a group of patients with a common syndrome, e.g., AKI as defined by KDIGO consensus criteria. Subphenotype describes a subset within a phenotype with unique clinical features. In AKI, subphenotypes can be characterized by various factors like etiology, risk factors, diagnostic features, and biomarkers. Endotype is a subset of patients sharing a specific biological mechanism of disease within a phenotype. Importantly, multiple endotypes can exist within a subphenotype or across multiple subphenotypes. Treatable trait is a characteristic within a subphenotype or endotype that can be effectively targeted by an existing intervention. In AKI, multiple pathobiological mechanisms often exist, making it unlikely for a patient to be defined by a single endotype. Some existing subphenotyping strategies can identify treatable traits, e.g., a negative damage biomarker in AKI associated with a DHF or hours. Subgrouping AKI enhances prognostic enrichment, identifying patients more likely to experience certain outcomes, and predictive enrichment, identifying patients more likely to respond to a particular therapy, leading to more precise management. AKI is not a singular disease but a complex, multifactorial syndrome. Its heterogeneity poses challenges for translating promising therapies from preclinical to clinical stages. This complexity is characterized by a range of pathobiological mechanisms like cellular dysfunction, hypoxia, and inflammatory responses. These may manifest as distinct subphenotypes or endotypes, which often overlap with other organ stress and injuries. Factors affecting the risk, progression, and outcomes of AKI include patient baseline susceptibility, illness acuity, non-kidney organ dysfunction, and specifics of the kidney insult such as its etiology, severity, and duration. The KDIGO definition of AKI relies on crude measures like serum creatinine and urine output, and lacks information on pathobiology. This leads to delayed diagnosis and hampers the development of targeted therapies. Acute kidney injury has various subphenotypes, grouped under the mnemonic, LIION. Let's break these down, starting with low perfusion AKI, previously known as prerenal AKI. The term has evolved to emphasize the distinct management each cause requires. The 3 V's affecting low perfusion are vascular, ventricular, and volume. Vascular issues can arise from systemic conditions like shock and sepsis, or local ones like hepatorenal syndrome, hours. Vasoconstriction can be due to eclampsia, hypertension, and even rhabdomyolysis, while contrast media may also play a role. Then there's intra-abdominal pressure leading to decreased blood flow. Ventricular dysfunction involves both left and right sides of the heart, including conditions like heart failure with preserved ejection fraction, known as HFpEF. Volume changes can be decreased due to dehydration or hypovolemia, or increased due to congestion and hypoproteinemia. Next is the inflammatory, immune subphenotype. Sepsis, for instance, can trigger AKI directly through pathogen-associated molecular patterns, PAMPs, or indirectly through damage-associated molecular patterns, DAMPs. Other contributors include acute glomerulonephritis and acute interstitial nephritis, or AIN. Obstructive causes depend on the site of blockage and lead to distinct subphenotypes of AKI. And under nephrotoxic and envenomation, toxins lead to direct acute tubular injury, ATI, or indirect effects causing AIN. Understanding these AKI subphenotypes aids in precise diagnosis and tailored treatment plans, stepping away from one-size-fits-all approaches to a more nuanced care for patients with AKI. Upon arrival in the ICU, patients undergo an assessment using the KDIGO AKI guideline. Clinical risk scores, like APACHE-2, SAPS-3, AKI-specific, RI, are used to predict AKI and mortality. Patients are categorized into low-risk and high-risk groups. High-risk patients are further assessed for AKI phenotype and tested for specific biomarkers to identify AKI early, including urine NGAL, urine IGFBP7-XTIMP2, and urine KIM1. AKI-specific supportive measures include optimizing hemodynamic and volume status, avoiding nephrotoxins and discontinuing certain drugs, maintaining glucose levels, monitoring serum creatinine, SCR, and urine output, UO. Additional information is collected to identify potential AKI subphenotypes such as changes in SCR or urine output. The cause of AKI, SCR trajectory and clinical presentation. Other biomarkers. There are two AKI subphenotypes, those with prognostic enrichment and those with predictive enrichment. Guidance is provided for supportive care, including renal replacement therapy, RRT, and further nephrology follow-up. Treatment is based on specific biomarkers, e.g., using vasopressors for hours, diuretics for ADHF, and corticosteroids for nephrotoxic AKI. Table summarizing the predictive and prognostic enrichment targets for AKI subphenotypes, their potential utility, and existing examples. If you enjoyed this video, don't forget to give it a thumbs up and subscribe for more informative content. So to summarize, consider individual AKI risk for all ICU patients. Pre-existing CKD, subclinical CKD, other chronic diseases, and acute illnesses add to the risk. Use SAPS, SOFA score, RI for better discrimination of AKI risk. Regular assessment, urine output, serum creatinine, nonspecific kidney damage and stress biomarkers, TIMP2, IGFBP7, NGAL, KIM1, LFABP, point-of-care assays like TIMP2, IGFBP7, and NGAL enable rapid diagnosis and AKI subphenotyping. Upon high risk or overt AKI, implement evidence-informed, guideline-directed measures to avoid further kidney damage. Use clinical features and biomarkers to inform specific therapeutic intervention. Research is ongoing to classify AKI into subphenotypes and endotypes, demanding new diagnostic criteria and the integration of new biomarkers, genomics, transcriptomics, proteomics, metabolomics. AKI subphenotypes characterized in sepsis, decompensated heart failure, hepatorenal syndrome. Endotypes emerging for catecholamine-resistant shock and acute interstitial nephritis. The goal is personalized care and improved predictive enrichment in clinical trials.